With that, I'd like to introduce Dr. Amy Garcia, who's a clinical associate professor and director of practice at the School of Nursing, the Department of Innovation and Practice. She has expertise in leadership, health policy, and informatics, and we're very pleased to have her with us today. She'll be introducing some of her colleagues as they present innovation and challenges ahead for the nursing profession. Amy, please go ahead.
Very good, thank you. Today I want to spend a little bit of time talking about the shortage of nurses and how we need to apply technology to deal with that. Be talking about our workforce center. I've got two colleagues to provide examples of things that they are doing, and glad to be here. So I got to say, I absolutely love your process model. I think it works, and it'll be a good way to talk about where we are at in our journey to form the Kansas Nursing Leadership and Workforce Center. So about a year ago, we identified a need for dealing with research on the nursing shortage. So we put out a call within KU and immediately had about 30 program directors and researchers raise their hand and say, I want to be involved. And here's what I see as the gaps. So we started meeting on a regular basis and started working on program applications and development. And we realized pretty quickly that we were part of a bigger problem. So we started engaging the community, and I'll be talking about that. And on August 2nd, we plan to go live with a center. We have projects in the works, and hope that helps. I want to say thank you to this group for your support in the metaverse, our virtual simulation partnership. I think this is really cutting edge for nursing as a whole, for healthcare as a whole, to be able to immerse from wherever you are into a healthcare setting. So those of us who were through COVID could turn on the news most any evening and see problems with shortages of healthcare workers, and particularly nurses. We think it's an unsustainable trajectory right now. I've been in nursing 40 years, and we've had shortages and off and on. This is probably the toughest one I've seen. So we project nationwide a need for 275,000 more nurses. We see about 20% planning to retire by the year 2020. It's a little higher than that in Kansas. Probably more concerning, 87% reported burnout last year, and the research says somewhere between 25 and 32% are considering leaving the profession. Kansas is no exception. We have right now a 22% year-on-year turnover rate, the highest it's been in Kansas. We project a need for 53,000 more nurses by 2026. So that includes 18,000 registered nurses, certified nurse assistants, and home health aides. The reason that's important, probably more shocking than the numbers, is the impact it has on our critical access hospitals. Kansas has more small critical access hospitals than any other state in the nation. We project roughly 30% of those are at risk for closure. What happens when you have a shortage of nurses is that you close beds, you divert patients, you close services, you lose revenue. It just aggravates the ongoing problem of small communities. So while the shortages are statewide, we are particularly concerned about our partners in rural practice. As we looked at the problem in Kansas, we realized that Kansas is one of 10 states that does not have a standing nursing workforce center. So we started wondering what in the world is happening. So we've done a drive-by survey, calling and talking with leaders in the other states about what they're doing, how they're doing it, how they're structured, what mistakes to avoid, and what does success look like. So I'll talk just a little bit about how that information is informing what we do. We are in the process of a set of 6 stakeholder meetings across the Kansas. Our goal is to really have a collaborative discussion. We have invited and have attendance from government agencies, large and small employers, industry outside of healthcare, associations, and both large and small schools. And we make sure that in each of our listening sessions that rural and urban settings are represented. They've been very informative. Our stakeholders and workforce centers across the state agree that we cannot simply educate our way out of this shortage. And in Kansas, we can educate roughly 1,890 nursing students a year. That's every nursing school in the state. We're somewhat limited by our ability to provide clinical experiences for nursing students, but that is 1/10 of the nurses we need. What we agree on with all of the workforce centers is that technology is a really big piece of the answer. So we look at it in our center as a continuum. We need better use and better technology in the pipeline. This would be in society as a general. So right now, the perception of nursing is somebody with their hand over their face, crumpled at the end of the hallway, worried about making it through the next shift. That does not represent all of nursing or the positives of nursing. We need better use of social media to tell a different story. We need technology in our high schools to give students the experiences of working with simulation or understanding in a way that young people understand new workforce settings. We are using technology in the classroom. We've got shared classrooms across the state. We think that standardizing curricula will allow us to share faculty across schools. We also want to work to bring technology, and the metaverse is a prime and cutting edge example of things that we can do to help students learn and have a really successful transition into practice. We need better technology in the practice environment. So many of the vendors around Kansas City are working on innovations like better staffing algorithms or use of technology or data that improve patient safety or access to care. Nursing practice, continually evolving. In my lifetime, I've seen a real transformation with technology. I think as AI enters practice, and we have decision support, I don't know, in Google Glasses or whatever, but we have decision support right at the point of care, it will make a difference in how we practice, how efficient and effective we are, and in the patient experience. And finally, we need decision support for policy. So I could talk for many hours about these bullet points, but I'm going to turn it over to a pair of colleagues to talk briefly about what they're doing. And then I will close this part of the discussion with some talk about our center vision for decision support for policymakers. So Dr. Michelle Cochran is a professor of population health, and Dr. Cochran, I will drive your slides, but I will turn it over to you.
Thank you. I'm going to talk about, do you have an echo when I'm talking? Or am I okay? Okay.
Yes.
I'm going to speak about the last couple of years during the pandemic, how we leverage technology to build and sustain our international relationship, our lessons learned, and how our next step would be to apply those principles and processes to building and sustaining local, state, and regional relationships. There were several programs that we did over the last 2 years that helped us continue our relationships internationally. One was virtual classroom exchanges, where we would have conference type presentations where we prepared students from Kenya, India, and the United States to present on topics that had a common theme: the impact of COVID on different populations, the impact of social determinants of health. They would present, break out into breakout rooms, and discuss and debrief. We also had, on a graduate level, a midwifery online exchange, the COIL, the Online International Learning, where midwifery students from Moi University in Kenya and at KU also would meet together in their small groups. So they worked together on presentations and studying contextual issues on interventions throughout the globe in midwifery. We had partner faculties from other international partners that helped our students understand what they learned in the textbook. I would have students study an issue, a health issue in a textbook, and then meet with our international colleagues to say how that applies to practice in real time, boots on the ground, frontline nursing. That was very effective in them learning, number one, from lower resource countries, how innovative they can be and how some of that can be applied to the United States, and also understanding the contextual issues of healthcare and how you need to innovate in various geographical areas. We also had practicums that were virtual, where our students were aligned with preceptors from other countries that helped them write grants or do surveys on food insecurity in other international settings. There were some lessons learned from that I'll speak to at one of the other slides. And we also have established annual roundtables with international faculty. And this year, the subject was teaching with technology. We had faculty members from Japan, India, Kenya, and the United States speak to faculty and students on successful interventions and learning outcomes of various technology that they're using within their nursing schools. We all learned something, to the point that next year we will have the same topic with some of the upcoming new technological features and have a collaborative that even includes more nations and more international partners. Next slide, please. What we learned in general about the benefits and importance that we learned, and there are some studies to support this. A lot of this was just experiential learning. As going through this, it does allow real-time collaboration despite the geographical locations. We could meet more frequently, establish trust, establish relationships at a foundational level, and build a shared mental model as we moved forward. It was a lot less cost with more participants. Instead of just a few people traveling, we could bring up to 200 students together to discuss health issues. So networking and partnerships and coming up with an insight that was multidimensional was a relatively ease virtually than if it were place-based. We found from both preceptors and students that when they met virtually, it leveraged their cognitive energy versus traveling. There would be some cognitive load with the time, the space, the environmental adjustments. And when they met in Zoom, it was as if there was a cognitive load that was eased and they could focus on each other's relationships, allow for creativity and intervention in addressing problems. And there was also a shared space that was regardless of geographical location. We also were able to pull in various perspectives. So if we felt like we were missing a perspective of a certain geographical area or a certain profession, we would bring them into the meetings, and that was done with relatively ease virtually. It would just add to the collective intelligence when we had partners that we could bring in to a meeting for 15 or 20 minutes. Next slide, please. So the main takeaways is that the virtual platform allowed for a third space that was inclusive and diverse. And that was important internationally because the hierarchy of power indifferences were minimized. You're in the same square, and whatever role you have in your institution, you are not sitting at a table and assigned seats. You're in a same size square randomly placed. And it was a more inclusive, diverse environment without a lot of hierarchy, which allowed for that shared experience and that shared mental model to be created, and allowed also to build trust with each other and learn each other's communication styles and vet each other's compatibility. So that was actually something that has not been studied as much as others that we're leaning into, because that was a common thread. Always, 100% of the time, both faculty and students said they learned the content. That was important, but it was the relational learning that made the difference. Discussing, debriefing, and embedding those thoughts cognitively was allowed more in that virtual space. So the relational learning was important to knowledge building. Again, it created a collective intelligence with collegial camaraderie in this third space that occurred in spite of geographical distance. So in summary, we found these processes for building and sustaining relationships through technology to be effective. They are sustainable. We actually have more and more international partners that want to join, and we do not have any trouble with creating new projects to work together because we feel like we have established that trust and established those processes. So we think we can apply those to more local and regional networking systems as well. Thank you.
Thank you, Michelle. I'll tell the group, there is a buzz in the school. The students are thrilled with what they learn and how they can apply it in the communities they take care of. So I'll now turn it to Dr. Laura Klinke-Boardman, and welcome, Laura, tomorrow. So.
Thank you so much. Yeah, so I wanted to just spend a couple of minutes here talking to you about leveraging simulation as a solution to a lot of the workforce issues that we have been talking about. And we know that is such a looming problem and has been a looming problem for quite some time in nursing. I always jokingly tell people when I'm talking about some of these workforce issues that all roads lead to sim. I truly do feel that simulation can be a huge solution and a huge way to kind of address some of these problems. Just to kind of give you a little bit of background about me and my simulation background, not only do I have a pretty significant simulation education background on the pre-licensure academic side, I also for the past couple of years have had a joint appointment in our health system here at the University of Kansas, doing simulation training and simulation-based research, looking at the outcomes of simulation on the actual practicing nurse side. And so I that's one of the reasons why I really see the potential for high fidelity interprofessional simulations to really bridge that, what we refer to in nursing as the academic practice gap, right? So getting students highly trained right before graduation in nursing school, they're not done. They're not, as I always tell people, they're not done cooking yet when they graduate. And we need to be able to use simulation to kind of bridge that gap and get them to transition to practice more smoothly as well, and continue their development and continue their training on the health system side as well. And so through simulation, we can see some really cool, interesting partnerships between academic and health system to partner to bridge that gap and kind of address some of these workforce issues. To that point, I mentioned that simulation can be a solution not only on the student side, but also on the practicing RN side to really bridge that gap. But, the other thing that I really see in terms of emerging technologies and simulation, specifically looking at and thinking about things like virtual reality and those types of things, is the equity that simulation can bring. We don't necessarily have to have boots on the ground learners right there in a simulation center in a brick and mortar space. With emerging technologies like virtual reality, we really can ensure equity, that no matter if you're at a big academic teaching hospital like the University of Kansas here in Kansas City, or you're in a smaller setting in more rural places throughout the state of Kansas, that we can ensure that learners and nurses and nursing students are getting equitable, immersive, experiential learning through technologies like that. And so I think that's another really big way that we can really think about bridging that gap and helping with some of these workforce issues, is the equity of learning that simulation can bring. And last but not least, one of the things that has really been something that I've been talking about with even just stakeholders around here at KU for a while now, is the use of simulation in kind of new or novel ways to develop skills that we maybe haven't necessarily always thought of as a skill that can be developed through simulation. Historically, we've thought so much about the development of the very tasky sort of clinical skills that you can develop through simulation. Obviously, when you think of nurses, you think of some of the skills and the tasks and the medication administration, the IV starts, and all of those types of things that simulation brings. But really, we can actually expand our thoughts and get a little bit more creative about the type of skills that simulation can foster, and think more even like leadership and professional skills. That can be a really big solution to some of this workforce development issues as well. So thinking about more professional skills, more interpersonal types of simulations that, a lot of times in nursing, we spend a lot of time on the clinical aspect of things. And then in terms of the leadership or the professional skills, we say, oh, that'll just come with time. That'll just come with time and experience. And once you kind of get into some of those jobs that you need to have those skills and grow those skills, you'll do it. Yeah, okay, sure, that probably is a little bit true, but why can't we actually more intentionally develop some of those skills early on through simulation-based experiences? Again, both, boots on the ground types of simulations, but also thinking about virtual reality as well. So that was just sort of a quick overview of some of the things that I'm excited about, given what I've seen in my joint appointment between the School of Nursing and the health system over the past few years. But, perhaps even more so, what I'm really excited about now in my new role as the new director of simulation here at the school is thinking about leveraging some of these experiences in new and different and novel ways to kind of address some of these sort of big problems in nursing right now. So thank you so much for your time this morning.
Thank you, Laura. And I'll say to the group, as we've done listening sessions through the state, we hear loud and clear that interprofessional simulation is going to be key. I'm hearing a lot of requests for help with psychiatric emergencies. So right now, we just don't have enough beds for psychiatric emergencies. So people end up staying in an emergency room for days on end. And the staff there on a day-to-day basis need help with understanding how to deal with that. And I think we can use technology in a number of ways, similar to what the Heart and Stroke Collaborative have done. But groups like this, to put our hats on and say, how can we think differently to provide care and equip people in the workforce to do that. So I'm going to close my comments with the number one request that we hear from stakeholders and the number one service provided by workforce centers across the state or across the country is better decision support. So what they're doing is integrating disparate data sources related to the supply of nurses, the education side, and the demand for nurses, the employer side. I think there's a lot of other pieces that fit into that. My dream for Kansas is that we have near real time interact, and I say near real time because the data on supply and demand lags just a little bit, and interactive dashboards with different focuses. The model used in New Jersey has approaches where you can look down through and understand how education is happening within the state. What do employer needs? There's a large data company that can give us the hot spots for healthcare openings and move that week by week. Community needs, demographics of nurses. So right now we can count the number of nurse licenses. We know that there are counties within Kansas that have 30 or fewer nurses. So if you think about that, it's truly a healthcare desert. So understanding when nurses are projecting to retire, what settings they're actually working in, it'll allow us to get at other kinds of information like understanding patterns of the types of nurses or healthcare specialties. Right now, we measure healthcare shortage areas by the presence of primary care and a dentist. What if we used algorithms? What if we used AI to better understand how skill mix in communities impacts outcomes in communities? I want us to be able to project needs so that when our legislature meets to allocate monies, they can really understand where we need seats in schools, where we need equipment, where we need new ways of thinking. So we are proposing, we're working on, we have part of our funding and people hired working on a one-stop shop for data and information and resources. The idea being that a researcher looking for information to write a grant can call us and say, okay, what does nursing look like here? How does this fit together? We want to support policymakers and we want to support nurses themselves through visibility to resources. So I will stop there. I will tell you we've got room on the bus for everybody. We're asking folks, will you join us? Making a difference, making sure that every Kansan has access to care. We think technology is a big part of the answer, and I will stop here and open up for questions.
Well, that's great, Dr. Garcia. Thank you very much. I was particularly interested in your comments and Dr. Cochran's as well about the positive elements of virtual meetings and virtual conferences, because I think coming out of the COVID experience, so many times we complain about what's been lost by virtual in terms of virtual meetings, but it seems that you found that there's a lot that's been gained because of that as well.
Absolutely. There's certainly been efficiencies, but I think there's been a new platform for creating, and we need to do better with the human technology interface here. But Michelle, would you like to comment any on how your students are benefiting?
Yes, I do feel that we thought it was a stopgap until place-based visits occur again, but we're finding that it's going to be compatible with actually being on site. But our preceptors and our students both want there to be more virtual collaborations until there is a need for you to understand the context in person. So if we were discussing interventions of some sort, we can do a lot virtually. Even in our virtual practicums, our students went to markets and farms and homes where they could understand contextual aspects of healthcare. I think it's here to stay, most definitely, in a large way that we maybe didn't realize 2 years ago. It's a preferred method of connecting.
Mm-hmm.
Yeah, that's very interesting. And we tend to be a little bit negative about it after COVID, but there's so many positive elements that are really brought to the fore now as well.
I think after 8 or 9 hours of meetings in a day, you go, too much Zoom. But if we're picky about how we use it. Yeah.
That's great. Other questions from the team?
One question I had is on the Workforce Center. How many nursing schools and hospital systems are involved in this project in Kansas?
So we are building those partnerships now. We are in the listening phase. We are purposefully partnering with other schools and other health systems to host those listening sessions to gain the trust that it will take. One of the partnerships that we have in place is our partnership with the community colleges for dual enrollment in an associate degree and a baccalaureate degree, with the baccalaureate portion being done online. We see every one of those schools and health systems as being the champion for the Workforce Center in their particular area of the state, and that we are truly stronger together. So, yeah. It's good. I don't have signatures on paper, but we will soon.
I was wondering, in terms of workforce, that I've worked in environments globally in which there were a lot of expatriate nurses. And I was wondering if what sort of room you see for that, helping to build our force of recruiting from other countries and then making sure that the nurses meet our current standards here in the United States.
Okay, so I am the former chief of the American Nurses Association, and we had a lot of ethical discussions about bringing large numbers of nurses from other countries and leaving those populations without nurses. I think our systems in place to test and back up do work. I think the kind of work that Dr. Cochran is doing, and as we get into virtual reality and the ability to share environments, we'll be able to better prepare nurses to come from anywhere to here. I also think that telehealth makes a big difference. So I'm working here. I may be taking care of somebody in Mexico or somebody in Asia. We do, I think Shauna Wright's on here can speak to what a powerful tool telehealth is. And I think nursing will always have a hands-on component, but as we use technology better, we will be more efficient. So an example is 20 years ago, we were first putting in remote telemonitoring into the ICUs and the smaller hospitals around. And we'd have nurses who were specially trained in that, or technicians, following those, and then calling and saying, your patient in room 201's in trouble. Let me get a doc on the line. This is what you need to do. I think that kind of work is and will continue to scale up, and technology enabled. The use of wearables by our patient populations enables us to provide care remotely. The world's our limit. We will always need to train hands-on, but we should make best use of people when and where they are.
Great. Other questions from the team?
Well, I may have a suggestion. Amy, when you're describing the dashboard you guys are working on, KC Tech Council just rolled one out for tech jobs in the area. They rolled it out a few months ago, and they used a local company, Pomerol Partners, which is a data analytics firm, to really develop that for them. So I don't know if you guys are looking for any outside resources, but when you were describing that, it reminded me of what they had done and who they used to do that.
So we are in, I will give them a call. And if you've got a name, just send it in the chat box. We are in strong conversation with the Department of Commerce on accessing and sharing data with them. So more hands. A lot of people think there's too many hands in the soup, but I think if we all bring our best. So anybody else that's got resources, we are delighted to hear from you and work with.
Okay, yeah, I'll shoot a couple names in the chat for you.
And I'll tell them I heard from you.
Great. Other thoughts? We've gotten really a great range of presentation this morning. I'm sure that there must be another question amongst the group.
You know, this is Shauna Wright. I don't have a question, but my encouragement for other schools and professions is to keep an eye on what's going on here with the School of Nursing. You know, throughout our state, but many states, we have those workforce issues, not only in nursing, but behavioral health and other healthcare providers. And really to watch what the School of Nursing has engineered here is really pretty phenomenal. And so my hope is not only to see the success and this continuous improvement that the School of Nursing is bringing to their process, but that also becomes a model for other schools and other professions, because we are just underserved throughout our state in many, many professions. But this initiative is really very important, and I think it's top notch. So I'm hoping not only do we see success here, I know we will, but that other programs follow suit and kind of build from that model as well.
Thank you, Shauna. I would like to think that there will be economy of scale as we build infrastructure, particularly linking outcomes to licensure or staffing patterns, that would be translatable to other professions. So.
Sadly, you know, telehealth does, in that aspect of it, telehealth does increase access, but it doesn't always increase workforce, right? So we might be able to better use our workforce and have less downtime, but then we have to balance that with the health and well-being of our providers as well. So leveraging the technology for training and assisting, you know, rural and underserved communities and developing those skill sets and those professions on the ground is imperative, at least in my opinion. And so I really appreciate the multiple uses and approaches to technology and how we can not only deliver service, but also help educate those in communities that are so underserved.
And take care of our providers.
Yes, absolutely.
Well, thank you so much for that. That's really, it's great to see such an earnest effort being taken to address a crying need. We really appreciate your sharing it with us this morning. So thank you so much.
And you all know where to find us. If you have questions or thoughts, just send us a note or give us a call.
That will be great. Thank you so much. Okay, just quickly, I either missed or people joined us later in coming on, and I might give them just a chance to introduce themselves while we have a little break here. Molly, do you want to say hello?
Sure, thank you, John. Good morning, everybody. My name is Molly Brown. I am the director of the Heartland Telehealth Resource Center. I've been with the TRCs for about a year, a little over a year now. Really briefly, we are part of 14 telehealth resource centers across the country, 12 that are regional and 2 that are national. Our national partners focusing on policy and billing and things like that, reimbursements related to telehealth. And then our other focuses on technology and different modalities and has a lot of toolkits and stuff available for that. Our TRC covers, we provide support in Kansas, Oklahoma, and Missouri, and are partnered with the OSU Health Science Center and then also the Missouri Telehealth Network. We provide outreach and resources, webinars, especially with the PHE coming to an end. We have a subject matter expert that focuses on billing and coding. So you can check out our website. I'll drop it into the chat if you have any. If you haven't visited us yet, we do have a newsletter as well, and a lot of other resources that we provide related to building telehealth or enhancing telehealth programs within our region.
Yes, your series around billing and coding was excellent with Rochelle Martin. That was just a great series. So I recommend people check in on that. I think I may have missed Sarah on our first go around. Sarah, are you still with us?
Yes, I am. Hi, everyone. I'm Sarah Sorek, Program Director for Digital Strategy at the University of Kansas Health System.
Great, thank you. Susan.
Hi, I am Susan Norris, just a retired but still interested party in healthcare technology.
Thank you. Lindsay? Lindsay, are you with us? Okay, is Elliot with us? May have gone on to other things. Well, with that, let's go ahead and jump right into our next presentation. It's one that we've been very much looking forward to. Dr. Shauna Wright is director of the KU Center for Telemedicine and Telehealth and a clinical assistant professor in the Department of Psychiatry and Behavioral Science. She oversees telehealth projects, technical assistance, and Project ECHO initiatives with statewide partners. And she serves as a telehealth consultant on national and state research and service projects, as well as a variety of Kansas coalitions and committees to support equitable healthcare delivery. So with that, I turn it over to Shauna to help us know what's going on for telehealth these days with the University of Kansas.
Thank you so much. Just as a brief introduction, thank you. That was a great introduction. I think I mentioned when I introduced myself that I am a rural health provider. I live and work in rural Southeast Kansas. I come up to our campus. We're actually located here at the Med Center campus in Kansas City. So I'm on the ground here in Kansas City, usually once or twice a week. My home is in Southeast Kansas, about 2 hours from here. And so my passion is not only for telehealth, but definitely leveraging technology and telehealth to meet some of the needs of our under-resourced and underserved areas. Those are passions of mine. Very fortunately, the KU Center for Telemedicine and Telehealth fits under KUMC's Institute for Community Engagement. So we're going to talk a little bit about what we've done and what we're going to do, where we're headed in the future. Keeping in mind that really historically, a lot of our work has been focused on that community engagement and rural healthcare piece. Since the pandemic, of course, we know telehealth can be a good fit for anyone, regardless of their particular resources. So I'm going to kind of go over a brief history. My talk is not as exciting as what we heard from the School of Nursing and the nursing leadership initiatives. But I'm so glad to get to meet you all and talk with you today, and hopefully find ways to collaborate and partner with you as we are advancing and making some shifts here at the Center for Telemedicine and Telehealth. I came on board here at KU in 2016, working with some behavioral health, telehealth grants. I became aware of KU, believe it or not. I was at the American Telemedicine Association conference in Baltimore, and someone said, "Hey, did you know what KU is doing?" And that's how I became connected with KU. I love being here and working here. I love our history. You know, when the pandemic happened, when we hit that public health emergency, our world became busier than it's ever been before, and people were surprised to learn that this center was established in 1991. So this year we're celebrating our 32nd year. It's one of the earliest telemedicine programs in the US. It's the first to have a school-based telemedicine project in the world. It was called Telekid Care. We really are the earliest and longest running tele-oncology program. We've worked with Kansas Medicaid and assisted with initiating that reimbursement as far back as 2004. Our center has won the American Telemedicine Association's award, and we are the home of KUMC's Project Echo program, and I'll talk about that here in just a minute. So we have a very rich history. One of the things that people sometimes do not understand, because we are part of the KU Medical Center, is that we're not part of the hospital. And I know that there are some from the hospital system here. So just to kind of carve out our niche, we are invested in innovation and research. We do not do service delivery. We do sometimes work with the hospital providers and connecting with rural and underserved areas. If those areas are not a part of the greater hospital network, we can help set up programs for areas that really need some specialized care, or if they're a part of a research program. But the hospital really does a great job with their telehealth program. They were ramping up really strongly before the pandemic, jumped in feet first and really fine-tuned their programming. They've got a great system. So again, the Center for Telemedicine is not a part of service delivery. We do not have a cost center. We are focused on research, innovation, and kind of advancing and developing telehealth. And sometimes we do that through projects to demonstrate the value, cost effectiveness of telehealth. But we do not have any clinical departments within our center. We connect with those and help support research in that domain. Find it. So who do we serve? Of course, we serve our faculty, our students, and our staff. We have strong partnerships with community providers and organizations. Sometimes we will have a department within the hospital system say, "Hey, we'd like some help exploring this or researching this area or that." And sometimes we have community partners reach out to us and say, "We are really deficient in this area. We really need some assistance or brainstorming around how telehealth can help our community." So we serve both organizations as well as the medical center. And of course, we work with telehealth patients. We work with advocates and policymakers. Our role there is to educate, explore, and problem solve in the worlds of telehealth. Believe it or not, because we have the word telehealth in our title, we often receive phone calls from patients of the health system and even not the health system. They'll look for telehealth support and they'll connect with us, and we support them to the best way we can, whether that's connecting them back with consumer and patient supports or doing some brief education to assist them. So right now, this is where we are focused in terms of the programs we deliver. There are some departments where we assist in the delivery of specific services. Many of those are behavioral health. In the last 3 years, we have really been focused on telehealth resource and consultation. I think I mentioned earlier that this is, since the pandemic hit, it's the busiest I've ever been. It's the busiest our center has been. And really, research really ramped down during the pandemic. Many of our projects had funds repurposed for COVID purposes. And we really were sought out very highly. There was huge demand for telehealth training, telehealth policy development, and really to assist organizations throughout the state in standing up telehealth almost overnight. So we've spent the last 2 to 3 years knee deep in providing resources, training, and direct consultation. And again, that includes with specific departments here with the School of Medicine, the School of Nursing, and our behavioral health departments, as well as community organizations, particularly those in rural areas that needed some hand-holding through that. We are really wanting to ramp up research and grant support as we are feeling less of a weight to support our community partners through the pandemic. We still will offer education, support, and consultation, but we're ready to grow in new areas. So we are exploring a variety of telehealth research opportunities, everything from digital health to patient nudges to some NIH activity. Right now, our NIH focuses in cardiovascular health, but we are looking for any opportunity to partner and advance research and really research beyond, this is telehealth research, but really we're looking at technology and healthcare innovation. We were lucky to meet with Doug Hohulin, and we'll look forward to interacting with him more in the future and looking at even AI and how our center can help research and inform some policy around ethical use of AI and development as well, not only in research, but when we consider how it's applied in the practice setting. Right now, much of our time and resources are spent on Project ECHO. The Center for Telemedicine is the hub and center for ECHO at the medical center. We are very busy. Many of our partners are state-based partners, the Kansas Department of Health and Environment. We receive funding from programs within the medical center, the School of Nursing, and other agencies as well. And we are very fortunate to have a newly developed partnership with United Healthcare, and we'll be delivering 5 echoes for them within this fiscal year starting July 1. The biggest project that will come out of that is a year-round school-based mental health echo that we will launch out in August. So we do a lot of work and I have a few slides on Project ECHO here in just a moment to explain that to those who maybe are not familiar with Project ECHO. And then our staff work and serve on various committees and coalitions throughout the state to help educate and provide telehealth expertise. And then our center is renowned for technical assistance. So when it comes to research, we are glad to be partners. Sometimes we're not needed as a partner. Our departments may have their own telehealth expertise within it, but sometimes they'd like some specific technical assistance, and our IT and technical system support have been doing this work for a long time, and they're highly sought after to support grants. So we assist with grants, everything from design and implementation consultation, as well as, as minimalistic as providing the tech expertise and assistance to make sure that the projects are running well. So this is briefly Project ECHO. ECHO stands for the Extension of Community Healthcare Outcomes. It really is, it's a model, it's a virtual learning model for medical providers. We find that not only medical providers, but also behavioral health providers really respond well and interact well with Project ECHO. And really what it does is we reach across the state. So we include urban all the way to frontier areas in the state, and we give providers real-time access to experts and to each other. We find that people learn best not only from experts, but when they can problem solve and wrap their minds around cases and collaborate together. So we use Zoom technology depending on our topic area. In a moment, I'll share some of our work in the past and some of what's coming up. But we found that ECHO was also very keen for addressing issues like professional isolation for providers who live and work in rural areas, who may not have a strong network of colleagues. ECHO is wildly popular. We have phenomenal registration and attendance to our projects. And really the goal is to increase the competence and confidence and knowledge of providers on the ground, so they can keep more and more of their patients and clients local without necessarily needing to refer to specialists in more urban or metro areas. So we pick topic areas, we make sure that our curriculum is built around the latest research, education, guidelines, particularly CDC guidelines when it comes to our opioid epidemic. But we work across various diseases, HIV, hepatitis C. We did tick-borne diseases, which was a lot more popular than we had expected it would be. We did not struggle to have providers show up there, and we wondered if we would. And we know that rural providers sometimes struggle to keep up with and even have access to the volume of the latest medical research. So ECHO really helps us disseminate that. So really the goal behind Project ECHO is to move knowledge, not patients. So we are leveraging technology to where our providers, whether they be rural, underserved, or even metro and under-resourced, to where they just don't have the time to really connect with our specialty teams. Our ECHOs are usually set up in an hour-long learning format where our specialty team will provide about a 15-minute didactic on a specialty area. And then the provider, the attendee, will present a case, and everyone in the Zoom meeting will consult on that case. So our hope with that, our aim for that, is that patients get the right care in the right place at the right time from their local and trusted providers. That our providers are getting new knowledge, they're treating more patients, and we're building community of practice and really building some of those networks and that collegial connection for our providers. Again, we're hoping that through ECHO, we're reducing healthcare disparities. We're helping local areas retain providers by supporting them in place, keeping patients local, not only for those providers, but even for when we look at hospital cost and laboratory cost. If we can keep some of those dollars local as well, we think that that's important. And just so system-wide, we're improving quality, hopefully reducing cost. Lots of aims there with Project ECHO. It's a really fun endeavor. Currently, we are wrapping up a substance use disorder ECHO. I will wrap it up this week. We will be launching out an ECHO this week. It's called What Matters Most, and that is an age-friendly approach to healthcare, primarily for older adults. We see the What Matters age-friendly approach being very effective in the hospital setting. This particular ECHO will focus on the nursing home setting. We will be launching out an HIV ECHO in August, a second SUD ECHO in September. And like I said, we have been doing needs assessment across the state. We will launch out our school-based mental health ECHO here in August, and we will work with those professionals throughout the academic year and into the summer next year. And I won't read through our whole list of different topics that we've focused on over the years, but I will tell you we did participate, and we were the hub with the National Nursing Home COVID-19 Action Network. That was a huge lift for our relatively small team, but we did a lot to help maintain and mitigate COVID in nursing homes here in our state through that project. So currently, much of our work right now has been focused on workforce development and telehealth education. We have strong interest in not only educating about telehealth, but leveraging technology to help with workforce development. So we have partnerships with the KU School of Social Welfare, the Department of Psychiatry. Our one of our favorite partnerships is with the School of Nursing. We find the faculty there to really be innovative thinkers and willing to be leaders in this area. We do a lot of work in the state with mental health centers. We have several projects going on with the Southeast Kansas Mental Health Center, but others, High Plains and Compass as well. And then of course we collaborate with universities outside of the state of Kansas, really focusing on workforce development issues. Project ECHO is a current initiative. We're really right now focusing on looking on having a more enduring palliative care ECHO. We had success with a couple of palliative care ECHOs last year, and we have partnered and work with the Governor's Palliative Care Council, and we're looking to do a more enduring program there. We are involved in telehealth projects and demonstrations. really right now we're looking at some digital health applications, and particularly in the SUD, substance use disorder domain. And then our staff are very active in advisory groups and committees, not only to educate about telehealth, but also to learn about needs, particularly rural, underserved, under-resourced areas, and work on designing applications for telehealth and health technology to meet some of those gaps and address those gaps. So in the future, we're going to continue with ECHO. ECHO is growing. There's strong interest, and we feel very connected with providers in building community of practice in a variety of healthcare behavioral health domains. And we are dedicated to any work that we can do with healthcare behavioral health workforce initiatives. However, the areas where we would really like to see growth in the next year to 3 years is research and innovation and health technology advancement. And again, stepping out of that traditional model of telehealth delivery, we will continue to support, educate, and connect our partners with the resources they need to have sustainable telehealth programs. However, where we're wanting to turn is health technology, innovation, and advancement, and really so that we can study it. We want to research it. We want to do some demonstration projects. We want to be able to demonstrate sustainability and cost effectiveness. And this is the area where we're really wanting to grow. This is our team. However, I'll tell you, there are 2 not pictured here, but we have this year added 3 additional staff to our team. Our team is growing because it has been so busy in our world, and everyone is dedicated to advancing technology. Each and every person that you see here has really great passions for leveraging and utilizing technology for healthcare outcomes, and they do that service not only through working with our center, but working on coalitions and collaboratives throughout the state so that we can help achieve those ends. So here is our contact information. I don't know why I didn't put that's our web, those are our websites. I can put my email in the chat as well. I don't know why it's not listed right there. But that's kind of our center in a nutshell. I know that as the pandemic hit and we consulted and worked on different groups, even legislatively with the modernization and reform of behavioral health, our legislators were somewhat shocked to know that we had been up and running for almost 30 years and that they had, local experts in the state that could help advise and consult with telehealth and that really rapid stand up that we needed here in the state. So I'm glad to take questions and to connect with you, especially if you are working in a domain where you would like to have a research partner.
Well, that's great, Dr. Wright. Thank you so much. I have a familiarity with the center going back into the 1990s myself. I used to bring international delegations to meet Dr. Doolittle and his team because there really was such an advancement of telemedicine for KU and Kansas, really above and beyond what had been happening in other parts of the United States. So the leadership shown there has really been remarkable over the years, and it's really great to hear it again, so to speak, to know just how much is going on there. So thank you.
And I have to say, I don't know if for those of you who haven't had the pleasure of meeting Dr. Doolittle, what a great guy. He's a very humble man, but such an innovative thinker, great leader. I'm very fortunate to be able to work with him. He's not as involved with our center. He is our medical lead here for the center, but truly fantastic person to work with.
That's great. What would be a type of grant that your team would be pursuing at any given time?
Well, actually, we'll look in any domain. Historically, many of the grants that have come through that have been centered here at the Center for Telehealth have been those HRSA, the Office for the Advancement of Telehealth, and HRSA. There really been more service grants. We have partnered with a lot with the School of Nursing and some of their NIH initiatives in studying telehealth, especially when we didn't have ready access to direct-to-consumer care, right? And so the pandemic happened, and then all of a sudden everybody can do direct-to-consumer. But really much of the work that's come through historically in the last decade have been the Health Resources and Services Administration grants, where really the idea has been to deliver services and have not been as research heavy, haven't had randomized controlled trials. And that's really the space that we'd like to step into. So more of the NIH space. However, you know, in terms of demonstrations, we're looking at a digital health application right now, and really the funding there will come from more foundational support, and our hope there is to get enough pilot data that to then turn to some of the more federally funded sources so that we can do randomized controlled trials with the digital health interventions. So we're open to any level, even, you know, to collect pilot data and learn from that and to try to grow out. We are doing some work right now with foundational funding in the remote patient monitoring space as well, particularly in our frontier areas of the state. And I know that I've met with some of you all here. It's not the same type of work that the group that visited our office is doing. It's a much smaller project, looking into more frontier areas where they're reverse engineering the technology and actually using landlines to be able to connect equipment, because especially on the western part of the state, we don't necessarily have access to broadband. And even if the broadband was there, the technology in the homes of older adults may not support those needs. But we're interested in it all, but the focus being to really look at outcomes and efficiency and applicability of different digital and healthcare technology interventions.
That's great. Any questions from the team? I guess I would ask, what kind of is the next most exciting thing?
I think that the next most exciting thing to me is also the most scary thing. Our staff, and again, thank you to Doug for coming in, and prior to visiting with Doug, our team has expressed interest just internally of looking into the AI space. And now that's more and more in the media and the news. As a center, you know, we have concerns for the ethical use of AI. You know, I like Doug did a presentation for our team and talked about the efficacy of AI being best when it's partnered with a trained provider, right? That it can enhance the work that provider can do, but it shouldn't do that work alone. So I think that AI is going to be the next exciting space. We haven't had the bandwidth to plan around that, but I think our initial steps with that are going to be partnering with the medical center to even discuss, you know, in terms of compliance training, how do we train students and faculty about what's okay and not okay under our roof with AI, not only in the educational space, but in the healthcare space, and you know, all of the HIPAA compliance issues that come along with using AI. So I think that's really where we're going to gravitate, but I also think it's the scariest space to step into because I think it's grown so fast and right now isn't regulated, that it needs partners in the playing field, not necessarily to pull in the reins, but to be that voice and kind of advise it as well. Because I think there's a lot of benefit that will come along with AI. There's so much more I need to learn about it, and our team needs to learn about it. But it's a game changer if it's done ethically.
Oh, yes. In fact, Casey Digital Drive is partnered with the Center for Practical Bioethics at looking at the ethical aspects of ethical dimensions of AI. It's certainly a very significant area. Other questions? Anything?
Great presentation, amazing work you guys are doing. Was curious what work you were doing from an education and collaboration with industry partners out there to make sure, as you talk about where technology is headed, how to make sure that they serve the healthcare community correctly.
Well, we typically, when we do training, we develop it and mold it to that industry leader. And so I will tell you, we are not out in the forefront of that space saying, here, we can help you. Typically, we're responsive. So if industry approaches us, then we try to understand their product, their application, and then train to that, particularly. We're not able to train on medical models, right? We train on telehealth models. We train on what's important to the patient. And really a lot of what we do is we help design and develop training plans. And so with industry, we haven't had a large spot in that space. I think the last really commercial partner that we had was during the pandemic, where some of the commercial insurers, which again, that's not industry, but commercial insurers approached us and said, wow, this is ramping up fast. How can you help us design training so that the providers that are impaneled with us understand not only telehealth, the technology, but also understand how to provide education to their patients. So it's a space that we're happy to step into. We're asked to develop trainings all of the time, but we don't seek that out. Usually we're responsive to that if it comes to us. Did I answer your question, Craig?
Yeah. Thank you very much. I'll follow up with you more later.
And I'll drop my email in the chat, okay?
Perfect.
No, that was a great question, very relevant. Thank you, Craig. Other thoughts by anyone? Okay, well, we certainly have benefited greatly from the University of Kansas today. As many of you know, actually, University of Kansas was very instrumental in the founding of KC Digital Drive. The chancellor had actually been one of the panelists that helped form KC Digital Drive when the two mayors of Kansas City, Kansas and Kansas City, Missouri came together to put their bi-state commission together to look at how things would develop with the advent of Google Fiber coming to town. And that was our origin. And so Kansas University has been very involved with us from the very beginning, and we're very grateful to have such dynamism still to this very day. So thank you very much for your participation and help today. It's great to see all the wonderful programs that are continuing to take place there. So we look forward to hearing more, and thank you again for today. And with that, I'll sign us off. And
John, just real quick, can I just take 2 minutes just to give a quick announcement?
Please do.
Okay. Yeah, so I'll just share my screen real quick. So, I wanted to highlight, do you see the VR-AR Association slide?
Yes.
Okay, yeah, so basically there's the Virtual Reality, Augmented Reality Association. So we've been having meetings now. This is going to be our third meeting coming up. It's in support of the Kansas City Digital Drive event. So our first kickoff meeting was at UMKC. We had over 70 people. We had 4 companies come in to give talks about what they're doing in immersive technology. So we did this at the UMKC Plaster Center. Was a really exciting opportunity of what's going on. So what I wanted to announce today is that we're going to be planning an event on Tuesday, July 25th. It's going to be between 5 and 6:30. What we're looking, and it's going to be focusing around VR, AR, but into generative AI and healthcare focused space. So, we are looking for a venue, though we may have some ideas of where to venue. So, but if you have a space specifically around healthcare, that would be fantastic. But really what we're looking for is 4 speakers that would be willing to give 10 minutes. So if you're doing anything around generative AI or AI in general, or XR, healthcare innovation, it would be a great time to have a speaker. Again, Kansas City Digital Drive is really supporting us and doing some great things One thing is the VR/AR Association. There's over 20 chapters around the world, and there's 60,000 subscribers to our website. So it's a big organization, and we're excited about here in Kansas City be one of the chapters. I also wanted to highlight that there's the VR/AR has a healthcare forum coming up on June 29th. It's free to attend. It's 3 to 4 hours where they have keynote speakers from Microsoft and so forth. Actually, we're going to have a panel talking about XR and generative AI and the impact to the future of healthcare. The people on the panel will be Denise Mead from Healthcare and Life Sciences at Microsoft. She was formerly director at Healthcare Watson. So I'm really excited to hear what she has to say around this space, especially with all the things going on with Microsoft and their announcements the last couple of weeks. And then Dr. Harry Castro, MD, author of Being Copilot and Other Large Language Models, Revolutionary Healthcare with AI. So with that, I just wanted to highlight that. I put my email in the link, so please just email me if you're at all interested in speaking or just attending. We'll let you know where the venue is once it gets announced, and it's free to attend. And so looking forward to having anyone here that's interested to be part of this.
Sounds great, Doug. Thanks very much for sharing that. Any other announcements? Okay, with that, I'll say again, thanks to everyone, and look forward to seeing everyone next month. And look forward to the participation of the everyone from University of Kansas again. Thank you so much. Bye now.